Imagine dedicating your life to healing, pushing through those grueling shifts, putting your own health right on the line, only to find your mental well being, your finances, even your precious family life just sort of silently eroded by the very crisis you're fighting. That wasn't just a hypothetical scenario, was it? It was the stark, lived reality for thousands of surgical team members during the height of the COVID-19 pandemic. Today, we're going to look far beyond just the medical statistics. We're unpacking the profound human cost, those overlooked struggles that quietly unfolded within operating theaters right across the globe, and importantly, what this tells us about the foundations of our healthcare systems. Welcome to the deep dive. This is where we unpack complex topics to give you the insights you really need to be well informed, cutting through all the noise to bring you vital understanding. Today, we're embarking on a really crucial deep dive into the profound impact of the COVID-19 pandemic on the global surgical workforce. And joining us to navigate this challenging landscape is Professor Mo Imam. Now, Professor Imam is an orthopedic surgeon, and he brings an extensive background in leading significant international research initiatives. His unique position, really, as both a clinician and a global researcher, makes him an unparalleled guide to discussing the global context and the nuanced implications of this groundbreaking work. Our mission today is to explore the multifaceted impact the pandemic had on the well-being of surgical teams, drawing on rigorous global data. So you're going to gain a comprehensive understanding of the real human cost and the systemic issues that this unprecedented crisis uncovered. These are critical lessons we absolutely must carry forward for the future of patient care. Okay, let's unpack this then. Professor Imam, to kick things off, could you give us your immediate top-level thought on what this research fundamentally reveals about the vulnerability of our surgical workforce?
Well, I think what's truly illuminating here is how this research pushes beyond just the clinical impact on patients or, surgical backlogs. It fundamentally reveals the unprecedented scale of the challenge for surgical teams. And that extends far beyond the operating theater itself.
Yeah.
Right into their holistic well-being. We're talking about, widespread impacts across physical, mental, financial, and family domains. It really laid bare how interconnected all these elements are, and crucially, how fragile the system can be when these sort of human foundations are shaken. This wasn't just a clinical crisis. It was a profound human one that affected, well, every facet of a professional's life. It shows us that our healthcare workforce is incredibly resilient, yes, but also profoundly vulnerable without adequate support.
And this study surveyed professionals across an astounding 54 countries. That's a truly global snapshot, isn't it? What, in your view, is the single most surprising global disparity in how healthcare workers were supported, and what does that tell us about where we might be perhaps looking for solutions incorrectly?
Yes, the scope is huge. If there's one finding that genuinely surprised us, it was the intriguing inverse relationship between a country's Human Development Index, the HDI, which, broadly indicates its level of development and resources and certain types of support. Now, you might logically expect that lower HDI countries with fewer resources would consistently offer less support right across the board. And, well, that generally held true for crucial things like personal protective equipment, PPE, and access to formal occupational health or mental health services. That wasn't a surprise. But we unearthed the paradox. Lower HDI countries were, counterintuitively, more likely to report having manager support and access to sick leave when needed compared to their counterparts in very high HDI countries.
Really? That is surprising.
It is. It challenges some conventional assumptions, doesn't it? It suggests that perhaps in environments with fewer formal resources, those informal support networks like direct managerial empathy or maybe culturally embedded norms around sick leave might become incredibly strong, perhaps even more effective in certain contexts. It highlights that support isn't just about big budgets. It's also about human connection and, well, cultural dynamics.
That's a fascinating twist on what one might expect. Really interesting. Finally, for this initial overview, if there's one key takeaway about the long-term implications for patient care from all of this, what would it be?
The overarching takeaway, the absolute core message is this direct, undeniable link. Staff well-being is paramount for patient safety. It just is. This study reinforces, with hard data, that investing in the holistic well-being of our healthcare workforce isn't merely an ethical consideration or, a nice-to-have. It is a fundamental public health imperative. When staff are unwell, stressed, burnt out, medical errors and adverse events demonstrably increase. We know this. Globally, these adverse events account for a staggering 64 million disability-adjusted life years annually.
Wow, 64 million.
Yes. And just to clarify for listeners, a disability-adjusted life year, or daily, represents 1 year of healthy life lost due to illness, disability, or early death. It's a profound measure of the global burden of disease and suffering. So ensuring our healthcare professionals are supported, healthy, resilient, well, that's the most direct pathway to improving patient safety and the overall quality of healthcare worldwide. It's not just a foundational piece. It is the foundational piece for sustainable, high-quality patient care.
Right. That's incredibly clear. Let's transition now from that broad, overarching view to the individual experience. We're going to dive into the core findings on the well-being of these professionals, moving from the global crisis to the very personal toll it took on each individual. So, first, on physical illness. The findings showed a significant portion of surgical team members experienced physical illness. What specific percentages did the research uncover, and perhaps more importantly, what factors were found to be most influential in this outcome?
Yes, the numbers on physical illness are quite striking. They paint a very clear picture of the risks surgical teams were facing day to day. Our research revealed that nearly a third of all respondents, precisely 32.0%, reported becoming physically ill since the start of the pandemic.
A third. That's huge.
It is. And that this wasn't just, a general malaise. Over half of these cases were specifically linked to COVID-19 symptoms, indicating direct exposure and infection due to their frontline roles. But what's truly crucial here are the factors we identified as having a strong statistical link to this outcome. Factors that really highlight systemic vulnerabilities. We found, for instance, that those with reduced access to personal protective equipment, PPE, so things like masks, gloves, gowns, they were a staggering 4.6 times more likely to get physically ill.
4.6 times.
Yes. It's a very clear, almost intuitive cause and effect relationship, isn't it? You can imagine going into an operating theater or a ward where highly infectious patients are being treated, but without adequate protection. The fear of contagion, not just for yourself, but carrying it home to your family, it must be immense. So this finding just underscores the absolute fundamental importance of providing adequate, consistent protective measures to frontline staff. It's not just about a mask. It's basic safety and, crucially, psychological security. But beyond PPE, there was another factor, perhaps less obvious but, equally impactful: regular breaks. Those who reported reduced access to regular breaks were 1.56 times more likely to report physical illness.
Okay, that's interesting. Breaks.
Yes. This isn't just about feeling tired. It's about a basic human need for rest and recovery, directly impacting their physiological susceptibility to illness. When you're constantly on the go, without adequate time to decompress, eat properly, or simply rest your body, your immune system is likely compromised. You become more vulnerable. It really raises an important question about fundamental worker welfare and its direct, measurable impact on their physical health. It perhaps suggests a culture where pushing through exhaustion is maybe glorified, often to the detriment of health.
It certainly does. That link between breaks and illness is fascinating, as you're saying, not something people immediately think of, is it? It makes you wonder how many times these professionals just pushed through, didn't they, putting their own health at risk just to keep the system running. And when key staff fall ill, especially such a significant proportion, like a third of them, what's the ripple effect on service provision, on staff shortages? This isn't just about an individual's health, is it? In fact, it sounds like a perfect storm for systemic failure.
Absolutely not. You've hit on a critical point there. This has profound systemic implications that just cascade through the entire healthcare system. When such a significant portion of the workforce falls ill, particularly those in critical surgical and perioperative roles, it creates immediate and often long-lasting problems. Firstly, there's that immediate impact on service provision. Elective surgeries, which were already suspended or drastically reduced during the initial waves anyway, they face further delays. This just exacerbates already burgeoning backlogs. It leads to patients waiting longer for essential procedures, which in turn can result in poorer outcomes for them, increased pain, a significant drop in their quality of life. Emergency services also become incredibly strained. Remaining staff are stretched thin, often forced to cover multiple roles or work outside their specialization, and that's just not sustainable. As we've discussed, it contributes to their own physical and mental fatigue, creating this vicious cycle where more staff fall ill or become too exhausted to work effectively. Secondly, it leads to severe staff shortages. The remaining team members are forced to work longer, often unplanned shifts, short-staffed. This increases the likelihood of errors purely due to fatigue. Imagine a senior surgeon or an experienced scrub nurse being out ill and a less experienced team member having to step into a high-pressure situation without perhaps the usual level of support. The long-term consequences can include increased burnout, a severe decline in staff morale, and ultimately attrition from the profession. Healthcare professionals, already dealing with immense pressure, might simply decide the personal cost is too high. They might leave, and that further weakens the healthcare system's capacity to deliver essential care. It truly underscores how a failure to protect the individual well-being of staff directly translates into a crisis for the entire system and for patient access to care. It compromises the very mission of medicine.
Shifting now to mental health, the statistics here are, well, quite stark, as you mentioned earlier. Could you elaborate on the prevalence of anxiety and depression among surgical teams and how these figures compare to, say, pre-pandemic levels? What did you find, and importantly, how did you measure it?
Yes, the mental health data painted a profoundly concerning picture. It really reflected the immense psychological burden placed on these professionals. We assessed anxiety using the Generalized Anxiety Disorder 7-item scale, that's the GAD-7, and depression using the Patient Health Questionnaire 9-item scale, the PHQ-9. Now, these are standardized, validated questionnaires. They're commonly used to screen for anxiety and depression, so they gave us a consistent and reliable measure across different populations and healthcare settings. Based on these validated scoring systems, we found that nearly half of the respondents were experiencing significant mental health challenges. Specifically, a staggering 46.9% experienced mild to severe anxiety, and 45.0% reported mild to severe depression.
Nearly half for both. That's incredibly high.
It is. And to put this into a vital perspective, we also asked participants to self-report their mental state from 2 weeks before the pandemic began. The comparison was stark. The mean scores post-pandemic showed a statistically significant increase. Anxiety scores rose by an average of 2.24 points, and depression scores by a significant 4.22 points. This isn't just a subtle shift. It represents a tangible and profound deterioration in the mental well-being of surgical teams during the pandemic. These figures are really at the upper limits of what has been reported in similar studies on healthcare workers during crises. It just highlights the severe psychological toll this unprecedented event exacted on those dedicated to saving lives.
It's sobering to hear those numbers, especially that demonstrable increase really puts it in context. What's fascinating here, though, is how various demographic and professional factors influence these mental health outcomes. You uncovered some really nuanced findings, didn't you?
Indeed, yes. The granularity of the data allowed us to sort of peel back the layers and reveal some unexpected but crucial insights into who was most affected and potentially why. For instance, when looking at ethnicity, we found something quite paradoxical. Individuals from other ethnicity groups were actually less likely to report increased anxiety compared to those of white ethnic backgrounds.
Oh, that is unexpected.
It is, especially given the known higher COVID-19 mortality and morbidity rates often observed in some of these groups in, say, the UK and US. Our study didn't fully explore all the underlying reasons, but one potential contributing factor identified was that this group was also less likely to have experienced a decrease in family time. So this suggests that maintaining strong family connections, perhaps augmented by existing robust community or cultural support networks, might have offered a protective buffer against anxiety, even amidst heightened external risks. It's a reminder that resilience can come from unexpected places. Regarding marital status, being married or in a relationship emerged as a protective factor. Those individuals were significantly less likely to experience increased depression.
That makes intuitive sense.
It does, yes. It aligns perfectly with established literature on the importance of social support and companionship during times of intense stress. Having that built-in support system at home, someone to confide in, share the burden with, or simply offer a sense of normalcy that clearly made a tangible difference in buffering against the psychological strain. And then looking at professional role and grade, which is critical for policy implications, trust grade doctors. Essentially, junior doctors, often in training grades, were significantly more likely to experience increased depression compared to consultants.
Right, the junior staff.
Yes. And this isn't entirely surprising when you consider their likely exposure and responsibilities during the pandemic. Junior doctors, often at the front line of initial patient contact, were highly susceptible to rapid redeployment to unfamiliar duties, sometimes completely outside of their specialty, often with minimal additional training. Imagine being a surgical trainee suddenly working flat out in an intensive care unit, witnessing profound suffering and perhaps ethical dilemmas daily. A scenario far removed from your usual surgical training environment. They also face significant changes in their family time, as we'll probably discuss. This combination of increased professional stress, potentially less autonomy, direct exposure to critical illness and death, and reduced personal life balance likely contributed significantly to their high rates of depression. It underscores the differential pressures placed on different tiers of the medical workforce and highlights the particular vulnerability of those earlier in their careers.
And beyond direct health impacts, the study delved into those financial and family pressures you just touched on. What did you find regarding salary decreases and time with family? And crucially, how did these factors intersect with mental health? This truly paints a picture, doesn't it, of a workforce under immense multifaceted strain where personal and professional lives became so inextricably linked.
You're absolutely right. The intersection of financial and family well-being with mental health was a critical aspect of our findings. It demonstrated the holistic and pervasive nature of the pandemic's impact. We found that a significant proportion, 29.0% of surgical team members, experienced a decrease in salary.
Nearly a third again.
Yes. And this wasn't just an inconvenience. This financial strain was strongly linked to worsened mental health. Those with a salary decrease were 1.5 times more likely to have an increase in anxiety and a striking 1.84 times more likely to experience an increase in depression. Now, this isn't just about lost income. It's about the added financial burden and insecurity during an already incredibly stressful and uncertain time. For many, this meant worrying about paying the mortgage, supporting dependents, or even just maintaining a basic standard of living. This kind of chronic financial stress can have a profound and debilitating psychological impact. It creates a vicious cycle where financial worries compound mental health struggles, which in turn can affect work performance and overall well-being. Similarly, time spent with family, which we know is a vital protective factor for mental well-being, was severely impacted for many. 35.2% of respondents reported a decrease in time spent with family.
Over a third.
Yes. And this, too, was significantly associated with increased depression. It made individuals 1.74 times more likely to experience it. This powerfully reinforces the critical role that a healthy work-life balance and strong family connections play in buffering against psychological distress. When those lifelines, those moments of connection, support, and normalcy are eroded due to overwhelming work demands, the impact on mental health is clear and profound. It leaves individuals feeling isolated, perhaps guilty, and without an essential outlet for stress. We also looked at which demographic groups were most affected financially and family-wise, and the results showed distinct patterns. For salary decreases, it was actually less likely for the 30-40 age group and for non-consultant roles. Conversely, consultants, who are often in an older age bracket and typically earn more through a mix of public and sometimes private practice, were more likely to experience salary decreases.
Why was that?
This is largely because the suspension of non-urgent elective surgeries in private practice, which forms a significant source of income for many consultants, directly impacted their earnings. So it highlights how different professional levels face different financial vulnerabilities depending on their typical income streams. Regarding family time, the decrease was less likely for other ethnicity groups and for those who were married or in a relationship again, aligning with our earlier discussion about potential protective factors. However, junior staff, specifically trainees, were 2.8 times more likely, and nurses were 2.05 times more likely to experience a decrease in time with family compared to consultants.
Right, so the junior staff and nurses again.
Exactly. This suggests that junior and allied health staff often bore a disproportionate burden of increased working hours, intense redeployment, and more direct, continuous frontline exposure. This led to significantly less time for personal life and family, and this just compounded their overall stress and vulnerability. So yes, it absolutely paints a comprehensive picture of a workforce under immense multifaceted strain, where challenges in one area spill over and exacerbate difficulties in others, creating a truly challenging environment for so many.
Okay, moving from that intensely personal toll, let's explore the systemic response. How well did institutions actually support their surgical teams during this period, and what significant global disparities did the research uncover in that support?
Unfortunately, our findings revealed significant and, frankly, widespread shortcomings in formal institutional support. Right across the board, access to crucial support mechanisms fell far short of established recommendations. We use guidelines like those from the British Medical Association as a sort of benchmark, which advocate for comprehensive well-being support for healthcare staff. And the reality fell short. For instance, only 36.0% of surgical team members reported having easy access to occupational health services.
Only 36%.
Yes, these services are vital for addressing work-related health issues, providing preventative care, facilitating a safe return to work. Yet a vast majority lacked ready access. Even more concerning, despite the clear and widespread mental health crisis we just discussed, just 44.0% had access to mental health services.
Less than half, even with those anxiety and depression figures.
Precisely. The gap is alarming given the high rates we observed. And beyond clinical and mental health support, basic welfare provisions were severely lacking. A mere 16.5% had access to 247 rest facilities.
15%.
16.5. Imagine working a 12 or 14-hour shift, being constantly on your feet under immense pressure and having no dedicated, comfortable space to just rest or recharge for a few minutes. And even more shockingly, perhaps, an even lower 14.2% had access to 247 food and drink facilities.
Wow.
This means many staff, particularly those working night shifts or extended hours, were left without basic sustenance, exacerbating fatigue and stress. These figures are strikingly low. They indicate a widespread systemic failure to provide even fundamental support for a workforce operating under immense pressure. It suggests that while the individual burden was extraordinarily high, the institutional safety nets were often inadequate, leaving professionals feeling, well, unsupported and isolated.
That's a stark picture of neglected basic needs, isn't it? Really fundamental things. Now, here's where it gets particularly interesting, because the study specifically looked at how a country's Human Development Index, its HDI, impacted access to these supportive measures. You touched on this earlier with that surprising finding about manager support, but what did this detailed analysis truly reveal overall?
Yes, this analysis truly highlighted significant global disparities, but also, as we discussed, those intriguing counterintuitive findings. The general trend, as one might anticipate, was that lower HDI countries were indeed significantly less likely to have access to critical resources. For example, participants from low HDI countries were a staggering 18.3 times more likely to lack access to personal protective equipment compared to those in very high HDI countries.
18 times.
18.3. That figure, the odds ratio, indicates a really strong, quantifiable association between a country's HDI and PPE availability. It speaks to profound resource deficits in these regions. You try to imagine working in a context where you're constantly having to reuse masks, perhaps, or where even basic gloves are in short supply. The psychological and physical toll must be immense. Similarly, these low HDI countries were nearly 5 times the odds ratio was 4.997, so almost exactly 5 more likely to lack access to occupational health services, and over 3 times an odds ratio of 3.36 more likely to lack access to mental health services. Access to 247 food facilities was also significantly lower in these settings. So these figures really underscore the enormous challenges faced by healthcare systems in lower-income nations, where basic infrastructure and financial resources for staff welfare are severely constrained. It often means that frontline staff are left to fend for themselves with minimal systemic support.
This truly raises that important question again, though, doesn't it? You mentioned that surprising countertrend earlier. Why were lower HDI countries more likely to have support from managers and access to sick leave? What might explain this apparent paradox, particularly when they lack so many other crucial resources?
It's a fascinating and complex paradox indeed. And it invites us to consider the nuances of support beyond just formal provisions, doesn't it? While lower HDI countries generally lacked those formal, resource-intensive support mechanisms like robust occupational health or mental health services, they surprisingly showed more likelihood of having support from managers and access to sick leave when needed. Specifically, they were less likely to report a lack of manager support. The odds ratio was 0.29 for lack of support, meaning they were significantly less likely to report lacking it. And similarly, less likely to report a lack of sick leave access, with an odds ratio of 0.38.
So significantly less likely to lack those things.
Exactly. One possible explanation, though our study didn't fully explore this, could be rooted in the pre-existing conditions and cultural dynamics in lower HDI countries. Often, these healthcare systems operate with chronic understaffing and perhaps fewer rigid hierarchical layers compared to higher HDI settings. Now, this might inadvertently foster a stronger sense of camaraderie, maybe more direct, empathetic relationships between staff and their immediate managers. When resources are scarce, interpersonal support networks might become even more vital and pronounced. There might be a collective understanding that they're all in this together.
Right, a different kind of structure.
Perhaps. Managers in these contexts might be more intimately aware of their team's struggles day to day. They might have a more direct, hands-on, less bureaucratic approach to offering informal support or facilitating necessary time off. Maybe there's a more communal or family-like ethos sometimes. It's also possible there's less stigma attached to taking sick leave when resources are already stretched thin and everyone understands the daily challenges. Conversely, in higher HDI settings, despite having more formal structures and more resources on paper, there might be different cultural pressures at play. For example, a strong culture of presenteeism, that expectation to work even when unwell, can exist. Or there might be more bureaucratic hurdles to accessing formal support or even sick leave.
That makes sense.
This could inadvertently make staff feel less supported on a day-to-day human level, or less able to take necessary sick leave without perceived repercussions or guilt overburdening colleagues. So it suggests that formal resources, while absolutely essential, don't always translate directly into perceived or effective support on the ground. And those informal mechanisms can play a crucial, perhaps underestimated role in workforce resilience. It just highlights the complexity of institutional support and how it manifests across diverse global contexts. It urges us to look beyond just the budget lines and policies.
That's a truly profound insight. Really gets you thinking about what support actually means on the ground. If we connect all of this, the personal toll, the systemic gaps, these global disparities to the bigger picture, what are the overall implications of these widespread support gaps, formal and informal, for the long-term sustainability and effectiveness of global healthcare systems? What's the real consequence for patients at the end of the day?
Well, the implications are profound and far-reaching. They directly impact the very sustainability and effectiveness of global healthcare systems. It's that simple. When healthcare professionals are inadequately supported, particularly in terms of their physical and mental well-being, it has a direct and detrimental impact on patient care. Exhausted, anxious, or unwell staff are simply more prone to making medical errors. Adverse events happen more frequently. This isn't just a theoretical risk, it translates into real suffering for patients. Globally, as I mentioned earlier, these adverse events account for that astonishing 64 million disability-adjusted life years annually. This represents a massive burden of preventable disease, disability, and suffering that is, in part, attributable to human factors including staff well-being, fatigue, stress. Patients face longer recovery times, they might require additional interventions, or, in the worst cases, experience irreversible harm. So the long-term viability, sustainability, and effectiveness of global healthcare systems hinge directly on the health and resilience of their workforce. It's unavoidable. If we continue to neglect the holistic well-being of our healthcare staff, we risk a continuous cycle of burnout, disillusionment, and attrition from the profession. Experienced doctors, nurses, allied health professionals may simply leave, leading to a critical brain drain, a loss of invaluable institutional knowledge and skills.
Which makes everything harder.
Exactly. It makes it incredibly difficult to recruit new talent and adequately staff hospitals and clinics. That leads to longer waiting lists, reduced access to care, and ultimately a decline in the overall quality of healthcare available to everyone. It creates a workforce that is not only personally suffering, but also less effective in its primary mission of healing. Therefore, investing in and prioritizing the well-being of healthcare professionals isn't merely an ethical imperative, although it certainly is that. It's a critical public health imperative. It is a fundamental strategy for improving patient safety, enhancing the quality of care, and ensuring the long-term viability and resilience of healthcare systems worldwide. It really is a foundational element for a healthy society.
Absolutely. All right, Professor Imam, let's move into a quick fire round now, just to distill some actionable wisdom from this incredibly comprehensive deep dive. Based on all these findings, what's one immediate quick win an institution could implement right now to bolster staff well-being? Something practical.
The most immediate quick win, I think, with a significant and measurable impact, is ensuring readily available, consistent personal protective equipment. That's number one. And critically, guaranteed access to regular protected breaks. Not just breaks on paper, but time actually free from clinical duties. Our study clearly demonstrated that strong statistical link between reduced access to these basic needs and increased physical illness. Implementing these consistently would be a foundational yet often overlooked step. It directly impacts staff physical health and, by extension, their capacity to work safely and effectively. It's about basic human dignity and safety, really.
That sounds deceptively simple, yet clearly profoundly effective based on your data. What's one key indicator professionals themselves should monitor regarding their own well-being? Something they might overlook in the daily grind.
Well, beyond the obvious physical symptoms like persistent exhaustion, I'd suggest paying very close attention to changes in the amount of quality time you're able to spend with your family or loved ones. That's a key buffer. And also, crucially, those subtle or early signs of increased anxiety or depression. This could be, persistent fatigue that isn't relieved by rest, increased irritability, changes in sleep patterns, maybe a loss of interest in activities you once enjoyed. Don't wait for these to become severe. Recognizing these shifts early and being proactive in seeking support, whether that's formal psychological services or simply leaning on your informal support network, friends, family, trusted colleagues, is crucial for your long-term well-being and, frankly, career sustainability. Excellent advice for personal vigilance. Really important. Looking ahead now, what area of research or intervention, perhaps not fully covered here, do you believe is most crucial for future understanding of healthcare workforce resilience? Where do we need to go next with this? That's a great question. Moving forward, I believe it's crucial to delve deeper into the long-term psychological effects of professional trauma and specific stressors. Things like the cumulative impact of redeployment to unfamiliar or high-stress duties, which many experienced, or what is known as moral injury, that deep distress that arises from witnessing or participating in events that go against one's core moral values. Things like difficult resource allocation decisions during a pandemic, for example.
Right, those ethical burdens.
Exactly. Understanding how these specific experiences impact resilience over months and years is vital. And exploring the effectiveness of various management frameworks and leadership styles in fostering well-being across diverse healthcare settings that would be invaluable for building more robust, more humane systems for the future. We need to move beyond just identifying the problem, which this study helps do, towards understanding the mechanisms of recovery and, crucially, prevention.
Fantastic. Okay, let's just recap a few key points for you, our listeners, to carry forward from this deep dive. First, the pandemic had a severe, quantifiable impact on the physical and mental health of surgical teams worldwide, an impact that extended far beyond initial estimates and was truly widespread across the globe. Second, the financial strain experienced by many, alongside significantly reduced time with family, profoundly compounded the mental health challenges for these dedicated healthcare professionals. It really highlighted the interconnectedness of their personal and professional lives under pressure. Third, our deep dive revealed critical global disparities in institutional support. Lower Human Development Index countries face severe resource shortages in things like PPE and formal services, yet, paradoxically, sometimes demonstrated unexpected strengths in informal support networks like direct managerial empathy and perhaps a different cultural understanding around sick leave. Fourth, and perhaps the most crucial point, prioritizing the holistic well-being of healthcare staff is not just an ethical imperative, it's a direct pathway to improved patient safety and better healthcare outcomes globally. A healthy, supported workforce is absolutely fundamental to a healthy and effective healthcare system. And finally, simple, fundamental support measures things like consistent access to personal protective equipment and the provision of regular protected breaks have profound and immediate impacts on staff health and the overall resilience of the healthcare system. These are not luxuries. They are absolute necessities. We really hope this deep dive has given you a clearer, perhaps more empathetic, and certainly more nuanced understanding of the immense challenges faced by our global healthcare workforce during an unprecedented crisis. If you found these insights valuable, please do consider sharing this deep dive with your professional network, maybe on LinkedIn or X, and leaving us a rating wherever you listen really helps others find the show. Thank you so much to Professor Moe Mum for his exceptional insights today. It's been a truly illuminating and frankly a vital discussion.
Thank you for having me. It's an important conversation to continue.
Absolutely. So, what will you consider differently about healthcare support after this deep dive? We encourage you to reflect on your own sphere of influence, perhaps spark a conversation within your own organizations or communities. Until next time, keep exploring, keep questioning, and keep deep diving into the world around you.